All right. I'm glad I remembered. Okay, so I'm going to turn it over to Dr. Peterson to introduce our speakers for today.
All right. So thank you to everybody for joining us. I think we've got a really great program lined up for today, some phenomenal speakers, and so I'm very excited to share with you. We have coordinated this program in honor of Black History Month, kind of focusing on the experience of Black people in healthcare. Both from the employment perspective as well as from the patient perspective. We have three speakers today. The first speaker that we'll be hearing from is Dr. Scott Finney. He was raised in California in the Bay Area, moved to Spokane in 1975, and played basketball at Gonzaga University. He earned a bachelor's degree in English with a minor in criminal justice, and in 1992 earned a master's degree in American history from Eastern Washington. He then returned to Gonzaga for a PhD in leadership studies in 2000 and completed a dissertation titled The Impact of the Removal of Affirmative Action Upon the Freshman Class at the University of Washington, Implications of a 10-Year Quantitative Study. Dr. Finney has been a faculty member of Eastern Washington University's Africana Education Program and Department of History since 1992. He currently serves as the department's senior faculty member, its director of Africana Studies, and the executive director of Race and Cultural Studies program. We're very privileged to have him here today. So I'll turn it over to you, Dr. Finney, and we'll pull up your presentation.
Great, thank you. Well, I'm glad to be able to share this time with you. I'm going to take you on a brief journey in 10 minutes or so on understanding barriers to healthcare from the African-American lens. And I think this is a journey that's ongoing, and I'd like to go to the next slide, which shows us there's been a constant social and systemic wall for African-Americans historically. And if you look at those 9 items there, of course, healthcare standing out so much as reflected in today's African-American longevity and lifespan expectancy and so on. But the fact is this was government endorsed. It was racial segregation based on the belief that skin color indicated inferiority and or superiority. And so that denial of access to those 9 items that was really, really quite impactful generationally for people of African descent in this country. And of course, the 10th item, of course, would be political representation and voting, which is to change those 9. But if you look at that matter there of healthcare, this is the one we're going to focus on today. Let's go to the next slide. And we all know that we've had a number of epidemics worldwide, and of course, the United States has had the Spanish flu, as well as we're still dealing with the hangover of COVID, of course. But what we have here is from about 1918 until April 1920. You've got about a 2-year span and 4 waves of the Spanish flu epidemic. And that's when the disparity and the inequity in healthcare really stood out because white hospitals would not accept Black patients. And because of that, as you can see, and you can read there, the establishment of Freedmen hospitals were created in response to the segregation that denied African Americans, especially during this time, the 2-year time of the Spanish flu. And because of that, that became similar in the way of higher education. The historically Black colleges and universities, we have about 107 of those still across the country. All of that was in response to being denied access. So then if we go to the next slide, we could see that from 1942 all the way until, 1932, all the way to 1972, there was something called the Tuskegee experiment. The government actually set up a experimental lab setting in the Deep South. And what they did in Alabama and Tuskegee was actually have 399 men among a number, and the number ended up being close to 700, but 399 who were not actually treated with what they had. They had syphilis, but the plan was to let them go through the whole experience and try and find out what is it like and what happens at certain stages and the final stage, and even what happens with the spouses and the kids. So for 40 years, from 32 until 72, the government did this without any acknowledgement or any approval or any truth disclosure of what they were doing. They offered them free meals. Of course, this was impoverished African Americans there in Alabama. They offered them a kind of a special for their burial sites that they'll eventually need, and they gave them free checkups for other things. So it was a major, major barrier when African Americans found out, of course, when the whole country found out in 1972, because of an Associated Press reporter. This began to double up what happened during the Spanish flu time, that there is a systemic barrier to keep African Americans from having, proper, equitable health care. And this has left a lasting impression that the government would do such a thing for 4 decades. Let's go to the next slide because of time. One of the most dangerous things is to give a professor some time here. I could I could roll this right into dinner time. But anyway, we'll go to the next case here. Again, what you see is a buildup of systemic denial of access when it comes to health. And Henrietta Lacks is a big, big story. Here we have a case that a lot of folks aren't aware, but Henrietta Lacks was diagnosed with cancer back in 1951, and they did a biopsy on her, and they began to use her cells for research without any acknowledgement to her or her family, and without any approval. And actually, we can say these HeLa cells, as they're called, are the first immortal human cells to be used, cell line to be used in medicine and science. And so 6 decades later, her cells continue to grow to this day for the advancement of science and medicine, and have actually made major steps of progress in leukemia, herpes, Parkinson's, the flu, sickle cell anemia. And all of this was done without any acknowledgement or approval to the family. And again, this builds up that case of a systemic, almost clearly intentional denial of access to just what we call human treatment and fair treatment to people when it comes to medicine. So this has built up and caused a kind of ongoing suspicion generation to generation. And then if we go to the next slide, we can see that W.B. Du Bois, who was the most profound and prolific historian of African American descent, in 1899, he wrote a classical book called The Philadelphia Negro. And what he did was point out and document with well-researched facts. Of course, back then, he had to do so in defense of what he was saying. And what he did was he showed that there are social walls, social barriers, not only in healthcare, but all across the whole horizon. And such is the case that African Americans cannot but be second-class citizens. And he documented that proof in 1899. And if you look all the way up at the top there, the Center for Anti-Racism Research for Health Equity, this now at the University of Minnesota and throughout the country. Now there's an established and I would say a mainstream American approach to turn around this problem of inequity and even this idea of intentional disparities. But from 1899 up till now, we're still struggling and of course still trying to, as you all know, meet the need of patients of African descent. So if we go to the next slide, what we see here is the fact that there's been this buildup of lack of access and highly, I would say, to the degree of mistrust and suspicion. Look at these 2 surveys in October 2020, during the time that COVID was just about to come our way, right? 7 out of 10 say that, this is African Americans across the country, they feel that they're treated unfairly by the healthcare system. And then 55% just plain out said they do not trust the healthcare system, over half of African Americans. And it's based on a kind of a cyclical patterned history that some of the things that I highlighted that add up to that. And then if you look at the November 2020, only 42% said they were willing to take a COVID-19 vaccine. So there's a lot of oral history about what happened with grandma, what happened with our uncle, what happened with great grandpa. And so what happens is you have a documented history, at least by oral standards, within families across the country that in the end feel like the best thing to realize is we're going to get the short stick when it comes to healthcare. So let's go to the next slide. And what this produces is so much mistrust and suspicion. And of course, you all as healthcare folks, you're not to blame for this. We've inherited this mess. It's on our shoulders now. And so, but as a result, what we can say is this: African Americans are, number one, less likely to seek or take medical advice. Number two, less likely to follow up on appointments or feel obligated to. Three, less likely to fill prescriptions. A lot of suspicion about side effects and unknown side effects and so on. Am I a guinea pig again, like the Tuskegee experiment? And then number four, more likely to despise the required code switching when interfacing with healthcare members. And that's the idea of I need to speak a different type of English. I need to be more professional in how I say things. I can't just be myself, and I really can't say what I really feel like saying, and especially in the way that I want to say. So all of that put together becomes a major, major block. So in closing, before I pass the baton on to my colleagues, the next slide in closing, what can we do? I would just say in general, rather than cultural competency, I think what we need is cultural humility. And that involves the idea of listening, which is quite different from hearing. Listening requires that you drop your perspective and take on someone else's lived experiences as genuine, validate them, and actually authenticate them. That will bring in a spark of trust. If someone feels they're really being listened to, everyone wants to be validated. And then with learning, taking the time to honor the process of getting to know patients will go a long way to overcome the generational barriers. And then finally, letting, and what I mean on this sense is giving the terms and conditions of the whole conversation to that patient, letting them actually take control of the interaction. That will bring in a trust that will actually melt away that suspicion oftentimes. And so in closing, I just want to make this one statement that I believe President Teddy Roosevelt said, and it's so true. People don't know, actually, we put it this way: people don't care how much you know until they know how much you care. And that is something I found in my educational experience over the past 3 decades, and surely in dealing with healthcare. People don't care how much you know until they really know that you have a care for them. Thank you.
Thank you so much, Dr. Finney. That was a great presentation.
Thank you.
So I just want to remind everybody, if you have questions for any of the speakers, please put them in the chat and I will write them down, and we'll have a Q&A session at the end of the program today. Next up on our agenda, we have David Jones. David Jones is a nationally recognized HR executive and transformational leader with more than 30 years of C-suite experience developing and implementing innovative human capital strategies across multiple industries. As president of Human Capital Consulting for Malin Hughes, David leverages his vast experience to design and build a consulting practice that equips their growing and dynamic executive search enterprise and provides a full spectrum of services, including broad-based talent and workforce solutions. Previously, David was the Chief Human Resources Officer for Stanford Healthcare, where he led the staffing and HR work streams for the opening of the new Stanford Hospital. implemented the Standout Employee Engagement Program, and developed new services and programs to support the caregivers and remote workforce throughout the pandemic. David hired Stanford Healthcare's first Chief Diversity, Equity, Inclusion, and Belonging Officer, and has had a critical voice as the health system has built out the strategy and framework for the DEIB program. David has a master's degree in industrial and labor relations from West Virginia University and is certified as a senior professional in human resources and an internal consultant in managing organizational change. David's considered a thought leader in human capital strategy and a popular conference and keynote speaker, having lectured audiences across the country and globally on topics such as diversity and inclusion, well-being, human resource transformation, and employee engagement. He's also written numerous published articles on related topics and is a contributing author of 2 books. So we are very fortunate to have such an esteemed group here today. David Jones has been working with Kootenai for the last several months. So I will give it over to you. Thank you.
Thank you very much for that great introduction, Emily. I'm looking forward to hearing from this guy. It sounds pretty impressive. No, just really a pleasure to be part of this panel. And I just really want to first acknowledge everyone here and your willingness to be part of this Black History Month program. As you know, February is Black History Month, and really the purpose of it is celebration, education, information, and engagement around history and issues affecting African Americans in this country from the past through the present day. And typically it's more celebratory and it's more focused on highlighting great achievements and accomplishments and a bit more upbeat. And certainly we want to get to that, but I think it's also important to talk about some of the continuing issues, challenges, and struggles. And so the intent here is not to in any way make this a downer, but certainly to provide education. But I think most importantly, to talk about what we all can do to be part of the solution as we address health equity issues globally and certainly in our own organizations. And so if we go to the first slide, I just want to share a bit. And let me also mention that I'm going to be speaking kind of both from my experience at Stanford as well as my current work. I was with Stanford from 2017 and just left there last February, the end of February. And so I was there through COVID. As you heard, I founded the initial diversity, equity, and inclusion program and was also part of a lot of the work in health equity. And so it really made sense to talk about work that we did there and work that continues on this topic, since that's really the basic experience that I have to work with. But I did just want to ground us in the World Health Organization's definition of health equity, which they consider the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. And so basically what they're saying is health equity exists when everyone gets the same outcomes, gets the same results without regard to race, economic situations, et cetera. And I think we all can acknowledge, as we saw from the information that we just saw, that that's not the case. And so what do we do to address and ameliorate that? And so the next slide, I wanted to talk about the work that we did at Stanford. And when you hear the name Stanford and you know about the brand of Stanford, a lot of assumptions come with that. Typically that everything's great, we're world class, we're doing so well, and we probably don't have a lot of these same problems. Well, I'll tell you that Stanford has a lot of the same challenges that Kootenai Health or any other organization is dealing with. And I think what maybe is unique about Stanford is their commitment to address it and respond to it. And I was really proud to be part of that. But when we began our health equity and our DEI journey several years ago, we did have to look in the mirror and say, although we say we want to give these great world-class outcomes to everyone, evidence shows that there are populations who don't get our best. And in particular, people of color and Black people in particular, we have a lot of evidence anecdotally as well as empirically that shows that our Black patients and families aren't getting our best in every situation. And as we were moving into the work around diversity and equity and also health equity, it just so happened that a number of really high profile situations occurred that brought everybody's attention to the reality of what was going on. There was one case where a Black fellow was part of a team to conduct a procedure for a prominent white patient whose family essentially requested or demanded that Black fellow not be allowed to be part of that procedure. And unfortunately, no one on the team stood up to the patient. And so this fellow went into the faculty lounge and essentially set it out. And then after the procedure was over, a number of our white colleagues came in and apologized for what happened, but none of them in the moment stood up and addressed the issue or did anything about it. And that became a real significant folklore for the organization as to what happens even in a place like Stanford and what we can do differently. There was another situation where a Black man had had a particular condition and had been in the hospital for a while, actually been traveling overseas and acquired a particular condition. He was in the room and it was time for discharge planning. The nurse was prescribing a particular medication, and it so happened that this Black patient's wife was in the room as well, and she happened to have a medical background. And as she was listening to the nurse prescribing the particular medication and how to take it, she recognized that this was not the best medication available, that this was a older version that had some complications and some limitations. There was another version that was available that had much better outcomes, much better prognosis. And so she mentioned to the nurse, well, isn't there, and she named the medication. And the nurse said, well, yes, there is that medication, but I was concerned that you may not be able to afford it, that your insurance may not cover it, or you may not be able to afford the out-of-pocket cost of that would come with this particular medication. And so the patient and the wife informed the nurse, the money's really not the issue, but we prefer to get the best care and the best treatment option for us, given this condition and given our desire to be able to recover from this condition. Well, it turned out that Black patient was the chairman of the board of Stanford Healthcare. And the nurse did not know that. He did not disclose that. But all of a sudden, you see, the highest profile Black executive leader, board chair, be treated just as another Black face, and a lot of assumptions about him that were made that affected his care or could have affected his care. And, thank God his wife was there and knew to make an issue and to request the more efficacious treatment. But what we do know is that every day those interactions happen where there's not a person to advocate and where a person of color gets an outcome that is not the best. And there were a number of other situations as well that were, again, very high profile. One involved an executive who came to the ER with her mother, and it was a Saturday. The mom wasn't well. The particular leader was dressed in sweats. And as they were describing to the particular ER doctor what was going on, the ER doctor just kept asking questions and taking them through all these different changes. And after a while, the executive recognized that the ER doctor assumed that they were drug seeking and began to use a protocol for someone who is a repeat drug seeker. And so, without any other evidence or other information than just looking at them, made the assumption that this woman was just there to try to get some narcotics. And that blew up and was just another really, really high profile situation that just pointed out how differently people can be treated. And even very well-to-do or prominent leaders are treated a certain way just based on the physical observation of their color. So as we got further into the health equity work, we began to study all areas of Stanford, and this included the education of students and of trainees, looking at clinical trials, looking at the various ways that we diagnose and treat in the clinical setting, even looking at the technology and the AI that's built into a lot of our protocols, and even looking at some of the medical devices. And we were just really amazed and embarrassed to find that at every level of the organization, research, education, and clinical care, measurable bias was found. And it was just amazing how insidious so much of this was and was built into so many things. For example, learning that pulse oximeters that you put on your finger to read the oxygen saturation give a different measurement based on skin color. And there are essentially calibrated for white skin. And so a person with darker skin doesn't get an accurate reading, is one example. There are race correction factors built into certain clinical algorithms. And when that race factor is built in, it changes how the person is treated in terms of particular early interventions, the opportunity to, again, be involved in clinical trials or to get other experimental or other types of treatment that would actually head off their condition. And very often, their condition is left to languish until they get to the point where much more extreme measures are required, such as surgery and other things. And all of this because that race factor essentially creates a different pathway of treatment for those patients. And just on and on and on at every level within the systems. And part of the issue and challenge here is that it isn't always a person's intention to discriminate or to treat someone differently, but they are working with tools, with systems, with computer programs and other types of AI, robotics, other things that are designed and built in with this bias at the core and into the coding. And so you can't help but to give a biased outcome when it's built in at that level. And even people that are looking and trying and intending to give great care, to be fair, and even to correct bias, they're working within these systems where so much of this bias is just really inherent. And so Stanford launched the Health Equity Initiative, and actually at this point it is the best in the industry. And I met with one of my colleagues earlier this week to just learn more about what's happened in the years since I've been there, and just phenomenal progress that they've made, but still huge gaps and just really a mountain of opportunity and challenges that they're still trying to work through. If we go to the next slide, this just shows a bit of the framework that Stanford put in place to address health equity. And sort of the point I want to make here, I don't want to try to in any way impress you with the sophistication of the chart, but I just want to talk about how it really takes a comprehensive approach. Because many of you are on this particular session because you're someone who wants to do good work, you want to give good care, you're a caring person, you want to treat people fairly, you want to do the right things, and you want to be set up so that you can do that. But often, again, if you're not in a system where these issues are being addressed effectively and you don't really have the support and the infrastructure, you're not positioned for success. And even to the point of some of the coworkers of the Black colleague, they weren't even trained or taught how to address or respond to those situations. And so while they may have wanted to do something, they weren't even put in the situation where they were told what to do. And so part of what Stanford did was to actually commit to this mission of maximizing the health of diverse individual populations. And so a very explicit mission and philosophy was designed and developed to provide the overarching guidance for this program. Next, there is the box, creating a culture of equity. And so there was this intention to actually challenge the infrastructure at every level to understand and address bias, to get to the systems and the structures that create bias and oppress marginalized populations. On the far right, putting in place this roadmap to reduce disparities. And so as we learned and identified these anomalies and these inherent areas of bias, we begin to put roadmaps in place to address and ameliorate those. But I really want to point out in the middle, which is really what I'm here to talk about, and that is that every worker knows how to operationalize advancing health equity in their daily jobs. So the bottom line is, if you as an individual, healthcare worker, nurse, technician, physician, whatever, if you don't understand what your role is and what you can do to address and ameliorate health inequity, how can an organization expect to have good results? And so all of our program was designed to put that healthcare worker in the middle, in the right position to do great work and to be able to fulfill their intention of providing fair care, high quality care, treating people well, and getting great outcomes. And then, of course, when all of these things work together, they do have the result of improving the individual and population health for every group, and certainly for those groups who've been disadvantaged. If we can move to the next slide, and I'm about to run out of time here, but I just wanted to give you just one picture of some of the things that we did to really help support our employees. And we ended up putting in place various training programs and policies. But this is just a one-page from a huddle sheet. And Stanford Healthcare had a very embedded quality improvement culture, and it involved doing daily huddles. Every team would meet first thing in the morning and have a huddle. And in those huddles, certainly there would be conversations about the day's agenda, about the particular patient load and other things. But we also use those huddles to provide key messages and training, and to make sure everybody across the organization was talking about the same thing at the same time. And so for this particular huddle message in July of 2020, we created tools to equip healthcare workers to be allies and to know what to say when they're in a situation where they observe a coworker or a patient being treated in a discriminatory manner. And I won't read these to you, and I think we'll be able to get these slides to you so you can actually look through this. But the point is, in excruciating detail, we describe situations that an employee might find themselves in, or that they might be confronted with by a patient or family member, and then what to do in those situations. And we have examples of the key components, and then the words that work. And so we would give them specific phrases to use, so that if this happens, here's something you could say. If a patient says something that is discriminatory, here's a particular response you could choose. Or if you observe something that really doesn't pass a smell test, what should you do? And in particular, we wanted to be clear that every person has an expectation and an accountability. It's almost like they say at the airlines, if you see something, say something. It's not acceptable to just watch things happen. And there was a time when, because we had such an emphasis on patient care and patient satisfaction, a lot of staff members felt that you had to follow the patient's requests. You had to give them what they wanted. You couldn't in any way turn them down or refuse their request. And as an organization, we hadn't clarified for them that your customer isn't always right. And that as an organization, we have certain principles that even if a patient has a certain request or expectation, if it goes against our principles, you're not obligated to follow through on that request. And in fact, if a patient refuses treatment from a particular member of color on the team, we can let them know that every person on our team is expected to provide care. They're qualified. They're here because we trust them to do the work that they do. If you're not comfortable with that person, there are other hospitals that are nearby that you can choose to go frequently, but you cannot be in this hospital and get this procedure without this particular person who's been assigned being part of your care team. And so just being able to have those policies clear and have those expectations clear, and then giving our team support as to what to do when these things happen, really was a complete game changer. And so all of a sudden now staff members are empowered, expectations are clear, rules and guidelines are laid out, and we can address those situations as they occur. One other thing I just wanted to mention, and down at the bottom of this, and you may not be able to read this, but it just makes the point that the person who's being discriminated against is not the one who's obligated to actually provide the response. It's really their team who needs to come around them and support them and to speak up and to take the initiative to inform the patient or the family member of what our policies are, what our expectations are, and how people should be treated. And so again, this is just one small example of the things we put together in order to support our caregivers and our providers in these situations. I think I might have one more slide, or was that my last one? That was my last slide. So with that, I will cede the time to our next speaker.
Thank you so much. Certainly that last slide is one of the most helpful things that I've seen in a long time. We have unfortunately seen some behavior like that within our organization, and to have that kind of toolkit is just so valuable. All right, so just a reminder, please put any questions or comments into the chat, and we will talk at the end. Next up on the agenda, we have Roberta Truscott, who is joining us as the chair of the Kootenai County NAACP Health Committee. So So after nursing a diverse population of sick animals on a ranch in rural Montana, Roberta pursued a career in nursing. She received a Bachelor of Science in Nursing and a Master's of Pastoral Studies. Her medical experience includes over 40 years working in a variety of healthcare fields, including hospital, public health, hospice, chemical dependency, and 9 years in the Occupational Health Department at Kootenai Medical Center. In addition, she worked independently as a certified biofeedback provider, in the Spokane and Coeur d'Alene communities, incorporating stress management and relaxation training with clients. Though she retired in 2014, she remains active in the community and now serves as chairperson of the healthcare committee for the local chapter of the NAACP. She's also currently working with Pacific Islander community of Spokane towards the removal of an offensive statue from downtown Spokane. In addition to hiking, biking, and cross-country skiing, her favorite pastime is pampering her 18-month-old granddaughter, Coco. Thank you so much for joining us, Roberta.
Thank you for having me. I appreciate being here today. I'll be giving you a nursing perspective on the Black history in healthcare. There's one thing for certain in the field of nursing and in the history of nursing is that we're really good about taking care of others for the most part, but we really fall short of taking care of ourselves. So I want to begin with what I consider essential, and that's self-care. So go ahead and go to the next slide, please. As a hospice nurse, I was told to include yourself in the care plan. If our cup is empty, then how are we going to fill another person's cup? It's important to provide ourselves with self-care. And a part of what happens is then you find more balance in your life. And when your life is in balance, then you can better care for your patients. So self-care, absolutely essential. Next slide. What does being more present really look like? I recently saw the movie Avatar, The Way of Water. And in the movie, Jake is received by a chief, and the chief says to him, I see you. What he's saying is, I see your true essence. I honor you. As a hospice nurse, our goal was to enable patients to live with dignity until they died. As healthcare providers, the goal is to treat people with dignity while they're alive, while they're our patients, while they're under our care. The same is true for coworkers and how management treats employees, with dignity and with respect. Sometimes, though, we may fall short. A Black man in our community, he shared with me how at a doctor's appointment, he had numerous questions for the doctor. And the doctor's response was, well, why are you asking me those questions? So the man went elsewhere, and he did find a local doctor who was very understanding, who listened and answered his questions.
Yeah, I don't know if I want to take an hour, but then I have.
I'm hearing a little voice in the background. Holistic nursing looks at the whole person, body, mind, emotions, and spirit. I failed to do that with a Native American woman when I said to her, when I look at you, I don't see your color. It took me 25 years, yes, I was a slow learner, to realize that as I said those words, I was really saying, when I don't see your skin color, then I don't see you. My granddaughter visited last weekend, and she had these colored lenses that she played with. They were purple, so she would see purple, and then she used a blue lens and she saw blue. We all look at life through a colored lens. However, I was only looking through a white lens. So when I saw this woman, I only saw white. That's a form of color blindness. The way we provide care is also important. A mother shared the story of taking her Black child to the ER. The person came in to draw blood. They walked into the room, saw the people, and then they walked right back out, didn't say a word. The mother said she felt dismissed, rejected. If only the person would have just said, well, I'm not I'm not familiar with drawing blood from a Black child. I'll find somebody else. But she said nothing. She just walked out. Care that is genuine and heartfelt, it creates a connection. And it really says to that patient, I'm here for you. I care about you. You're not alone. Go ahead and go to the next slide. We're going to take a look a bit on Kootenai health demographics. And if you look at Kootenai County, it's estimated that about 900 Black people live in Kootenai County. And in the recent census in 2022, well, this would be estimated from 2020, that was about 0.5% of the Kootenai County population. As far as Kootenai Health employees, a single snapshot was taken in May of 2022, and it was estimated that Kootenai Health had about 309 employees who identified as BIPOC, which would be Black, Indigenous, or people of color. That's less than 1% of all employees, though it could be more because there were some that did not answer the question. As far as patients, between March of 2022 and February of 2023, between 1% to 2% of the patient population identified as BIPOC. Though there was about 35% of all of the respondents that some did not identify a specific category of race. Another tidbit to be aware of is that in Kootenai County, about 15% of the population is uninsured. And in Idaho, the ratio of a primary care provider to a patient is 1,520 to 1. Kootenai County is better, is 770 to 1. Though in Kootenai County, it's still a challenge to obtain health care. My daughter even recently moved back to this area for a short time, and it took her 8 months to find a new primary care provider, and she had insurance. Let's go to the next slide. Is there racism in nursing? Absolutely. I didn't want to believe it, but I found out it's true. The American Nursing Association formed a commission to address racism in nursing in 2021. And this is how they describe racism: assaults on the human spirit in the form of actions, biases, prejudices, and an ideology of superiority based on race that persistently cause moral suffering and physical harm of individuals and perpetuate systemic injustices and inequalities. From 1964, ANA excluded Black nurses. And even though they were allowed after that time, the Black nurses still felt like they weren't promoted to leadership, and they felt like they weren't valued. So the Black nurses, as well as Hispanic nurses, formed their own organizations in 1973 and 1974. Next slide. This commission then did a survey on racism in nursing. And I have to tell you, I was quite surprised by these statistics and saddened by them. 63% of the respondents, and that was out of 5,600 nurses, 63% said they were personally experienced an act of racism. 66% said the transgressor was a peer. And 60% the transgressor was a manager or supervisor. What happened to teamwork? 56% said the workplace racism negatively impacted their professional well-being. So what is being done to address racism in nursing? Next slide. The ANA did issue a racial reckoning statement, and in that they recognize that issues of racism persist today and continue to harm nurses of color. The ANA leaders apologize for the harm caused to all nurses of color, patients, families, and communities. They made a commitment to continue to support the National Commission to address racism in nursing. And they advocate for the reporting of race and ethnicity in professional journals and publications. They're actively engaged in a program of diversity, equity, and inclusion within the association. In their concluding statement, they said, we strive for anti-racist nursing practices and environments. Next slide. The American Medical Association has also reckoned with medicine's history of racism. In 1845, the AMA excluded women and Black physicians from representation in the House of Delegates. In 1964, the Civil Rights Act was passed, which then banned race and gender-based discrimination. Now, in 2008, the AMA did publicly apologize for the past discriminatory practices against Black physicians. I found it quite interesting, though, they never apologized to the women. In 2019, they did create a Center for Health Equity, and in 2020 recognized that racism is a threat to public health. Here's a statement by the director of AMA. Systemic racism in medicine is the most serious barrier to the advancement of health care and health equity and appropriate medical care. Next slide. So how have racial health disparities impacted the Black community? Here's an example of how COVID impacted the community. 2019 is the blue line and the orange is the 221. And COVID began in the United States January 20th of 2020. The first case was diagnosed in Washington State. The Black population lost 4 years of life expectancy. The one that was worse than that was the American Indian Alaska Native. They lost minus 6.6. And the white population minus 2.4. So certainly COVID impacted everyone, especially the Black community. Next slide. Another area of concern is the US infant mortality rates. A Black baby is 2.4 times more likely than a white baby to die in the first year of life. And sadly, the US is ranked number 33 out of 36 developed countries in infant mortality. Yes, more must be done. Next slide. What about maternal mortality rates? A Black woman is almost 3 times more likely to die than a white woman during pregnancy and up to 42 days after the termination of a pregnancy. A Black woman shared with me her childbirth experience. This was out of state. It was her first child and she had an on-call doctor. Her water broke on Friday, but a C-section wasn't done until Monday. In between, she had unbearable pain. This is a sad thing. Many times women and men that are Black are not believed when they are telling their healthcare provider that they're having pain, because somehow healthcare providers may think that this person has a high tolerance of pain. Well, eventually the nurse did listen, and she told the patient that she would give her a shot. Well, the shot was in her back. That was actually an epidural, but she didn't realize this. So when her legs went numb, she panicked. She didn't know what was going on. The nurse didn't listen and was frequently on her phone during the encounters. And when this one particular nurse would check her for her dilation, it was extremely painful. When other providers checked her, she said it wasn't painful. Finally, she told this nurse, "I don't want you checking me anymore." But then she worried, well, would this nurse retaliate? So it was a very stressful time for her. Eventually, with the C-section, she gave birth to that 10-pound baby. No wonder he wouldn't come out. She said, "I almost died there." And what she learned was the last place I wanted to be was at a hospital. Well, through that encounter, there was one on-call doctor that she met, that she connected with, and some years later, he was her healthcare provider, and she did have another delivery that was very smooth, and successful. Next slide. What other diseases are impacting adults, in particular Black adults? Hypertension, diabetes, and obesity are the key ones. And as you look at the graph, the Black population has the highest in hypertension and obesity, and they're second in diabetes. When I worked in downtown Denver as a public health nurse, the area I served was called the Projects. I worked with lower income members of the Black community. Many suffered with these diseases. Healthy food was a challenge, though. Many were on food stamps, and they selected foods that were high in carbs to stretch their dollars. There were also food deserts, so healthy food was not very available. Some people would say, oh, if only they just pulled themselves up by their bootstraps, they'd make a go of it. Well, when I worked as an OB nurse, I saw a lot of babies born without bootstraps, and some of them didn't even have boots. You see, people are born with a set of different life chances. Next slide. In light of this Black history in healthcare, what steps can be taken to provide more inclusive care? It really begins here in the heart. It's about self-care and including yourself in the care plan. And when you care for yourself and you live from the heart, then when a patient speaks to you, you can listen. I hear you. And if a patient tells you they have pain, believe them. I believe you. And you treat each person with dignity and respect, no matter the color of their skin. I see you. And when you do these things, inclusive care conveys this message: I will walk in solidarity with you. Next slide. So as you leave here today and move forward with your coworkers, your management, and your patients, reflect on these words from an African proverb. If you want to go fast, go alone. If you want to go far, go together. That's my last slide. Thank you all for being here and for listening.
Thank you so much, Roberta, and for the rest of our speakers. Thank you so much. I think this was an incredible program. We have just 1 minute for a question, and I wanted to pose this to David, hopefully. There was a question from Della Jenkins. Any plans to incorporate this material into our policies and procedures? And if not, you know, how would we go about asking for that to be done?
Yes, so we are certainly working with the Kootenai Health Leadership Team now on primarily putting together a statement, a philosophy statement on diversity, equity, and inclusion. And that really is where everything begins. I think from there, once we get that statement documented, we can begin to address specific policies and other programs, whether those be in hiring or clinical care and otherwise. And so these types of things that I was showing you from Stanford, again, those flow from pretty long-term commitment and organized approach and policy. I think Kootenai is a bit behind, but is certainly on the same path.
Great. All right. Thank you so much to everybody for listening and being here with us today and celebrating Black History Month by learning. In closing, next month we will be having our book club, our Inclusive Care Book Club, and this is also inspired by Black History Month. The book we'll be reading and presenting on is called Black Man in a White Coat by Damon Tweedy. One doctor's passionate and profound memoir of his experiences Grappling with Race Bias and the Unique Health Problems of Black Americans. So I would encourage everybody to attend the book club discussion, even if you do or do not have a chance to read the book, but it is a great one, very engaging and informative. So thank you everyone for joining us. Have a great Friday and weekend.
Bye-bye.
Everybody.
Bye.
Bye-bye.